Hi, everyone, and welcome to the SRHM Podcast, which explores new research and emerging trends in the field of sexual and reproductive health and rights, with a focus on using rights-based knowledge for action.
Welcome to the SRHM Podcast, everyone, where we explore the intersections of health, rights, and justice through rights-grounded evidence and lived experience. My name is Julia Hussein. I'm a member of the Board of Trustees of Sexual and Reproductive Health Matters, SRHM. And today, the podcast brings us to Kenya, where despite restrictive abortion laws, people are managing to access safe abortion care online. We're discussing findings from a new study entitled Telehealth Abortion Services via Women on Web in Kenya, 2013 to 2019, a descriptive analysis of the characteristics and motivations of the care seekers, published in Sexual and Reproductive Health Matters Journal last month. The study analyzed data from people who completed an online consultation. Joining us are three of the study's authors: Céline Miani, Professor of Social and Gender Epidemiology at Bielefeld University in Germany; Kenneth Juma, Senior Research Officer at the African Population and Health Research Center, APHRC in Nairobi; and Hazal Atay, researcher at Women on Web and postdoctoral researcher at Sciences Po Paris, or the Paris Institute of Political Studies. Thank you all for being here. I'll start by asking Kenneth to set the scene. Kenneth, this study is based on data from people in Kenya. Can you tell us about the context of abortion services in Kenya, including abortion laws, policies, and specifically any changes in Kenya during the period relevant to the study?
Yeah, thank you very much for this very important question. Indeed, in the last 10 years, Kenya has seen shifts in terms of policy. Sort of the SRHR landscape has shifted sometimes to the positive, but also to the negative. I'll begin perhaps by describing the legal context, which remains largely restrictive, allowing only abortions in very limited situations. That is, if the health or life of a woman is at risk or if she's in need of emergency treatment. However, through a court ruling in 2019, the High Court opened up grounds for abortion when there has been sexual violence. So those are the three main conditions under which abortion is delivered. However, we know that unintended pregnancies remain very common. Based on very latest data, we have unintended pregnancy rates of about 120,000 women of reproductive age, which is fairly high. And this is, of course, born of women finding it difficult to acquire or access modern and effective contraceptives when they're in need, especially for those who are married and perhaps young, but are sexually active. So as a result, then we have these huge amounts of unintended pregnancies that occur within different contexts, sometimes also within sexual violence. Then women have to navigate the space of abortion, being largely restrictive. Abortion stigma is very pervasive. Women known to have had an abortion are extremely discriminated. And so women's trajectories are normally complex, shrouded with limited knowledge, but also with limited access to safe abortion services. So as such, then often women resort to unsafe methods and procedures, which have been known to contribute to significant proportions of morbidity and even mortality. So abortion-related deaths, not as common, but they are common. However, what is common are complications, some of them very severe that leave women with lifelong disabilities. The expansion of medication abortion in the Kenyan landscape has opened up a route to redirect women's trajectories as they seek this critical reproductive health service, such that women are able to informally access medication abortions through various platforms, including online platforms that have sort of opened up a way to women to still navigate the difficult legal terrain of abortion, navigate issues around stigma, but then be able to still access these methods. And increasingly, what then is reflected in data is that when you compare abortion complications from 13 years ago to now, you see that there's been a reduction of severity of complications, reflecting that, there's been this open space for medication abortion, which is largely safe and effective. But an important last point I want to raise is that women visiting health facilities for post-abortion care has also risen, again, for a number of reasons, including that the primary healthcare system has broadened. But because of medication abortion, women are able to perhaps acquire the medications, as I was saying, informally, but still visit the facility just to confirm if what they're seeing as sort of the outcome of, the abortion, most commonly bleeding, is okay, is it normal, but they are not presenting with severe complications as we used to see 10 or 15 years ago, where women would come with very terrible medical conditions that would require admission to ICU and operation by highly professional and skilled providers. I'll stop there. I think that is a basic context to give for now.
Thank you very much, Kenneth. That was a very succinct summary of the legal context and the consequences of how this affects health services in Kenya. So I'd like to turn now to some of the specific findings of the study to answer the question, who uses teleabortion and why? Hazal, can you clarify what is meant by health abortion services and tell us a little bit more about the data you analyzed, what kinds of people were using teleabortion services, and what were their main motivations?
Of course. So when we talk about telehealth, we are essentially talking about remote healthcare delivery, and there can be different mediums of telehealth. But in the framework of this study, we are talking about Women on Web, which is an online abortion service. And so when we look at the socio-demographic characteristic of individuals in the study, we see that almost half of them are between 20 to 24 years old. Almost 65% of them are located in Nairobi and central urban regions, and a predominant majority of them have access to hospital within 60 minutes distance. And again, a predominant majority did not have a miscarriage or abortion before. So really our sample here is what we're talking about is a young urbanized population for whom this is the first pregnancy experience. And in terms of reasons and motivations, the study, our findings show that actually individuals have miscellaneous reasons for using online abortion services and for coming to Women on Web. So some of them, our findings show that actually more than half of the people asking help of Women on Web from Kenya do so due to legal restrictions. So this is 52% of individuals. And this is followed by the cost of abortion in formal or informal but local care settings, with almost half of the individuals reporting cost as a reason for asking help through Women on Web. And the third most prominent reason is really motivations related to privacy and secrecy. And it seems like telemedicine or telehealth offers more privacy to individuals. And that's the reason why they are coming to this service, to Women on Web. And in addition to these, there are several other reasons that we reported, like people have work and school commitments, childcare, distance to clinics. Some prefer self-management. They want to be at the comfort of their home. And actually, when we look at these individual reasons and circumstances all together, what we observe is that there are what we distinguish in the study, 3 umbrella motivations, if I might say. And really, these concern access, stigma, and empowerment. So individuals may be choosing telehealth because of access problems or stigma associated with local care or formal care in their own setting, but also because they want to self-manage their abortion, they want to be comfortable, be at the comfort of their home during the process, or just they want to have someone they trust with them during the process. And when we really compare these findings with other research conducted by Women on Web, what we see is that really the findings are similar in Kenya than what we found in several other countries. And individuals are actually choosing telehealth, both from a place of restrictions, because they have restrictions in their settings, but also from a place of empowerment, because they want to self-manage their abortion.
Okay, thank you very much, Hazal. As a continuation of what you were telling us about the health system earlier on, Kenneth, perhaps we can ask you what these motivations Hazal was describing can tell us about people's needs and limitations of the current health system.
Thank you so much. So in terms of the limitations of the health system, I'll begin exactly from where I stopped, but then also link with what Hazal has mentioned. the fact that abortions are legally restricted basically means that you are telling women to, because women will still have abortions no matter what, you're telling them to go and do whatever they want to do out there. Then if they survive, they should come to the hospital to be attended to. That is what the public health system is doing, because there's no safe or legal abortion within public health systems. Most of the safe abortions provided are provided by the private sector. So this is a strong and an important limitation, because then the Ministry of Health needs to be responsive to the reproductive needs of women. They should not leave it out there as it is unattended to, leaving women to do whatever they want and then claiming that they're ready to provide post-abortion care. But linking back to the findings, the legal restrictions mentioned as one of the greatest motivators to seeking telehealth services is very harmful to women. It limits women's autonomy and reproductive agency, and it does not prevent abortion from occurring. What it does is it redirects women towards other methods of abortions, and sometimes not safe, because from data, only 24% of all abortions normally are safe. The others are unsafe to different degrees. So the legal restrictions are known to be harmful, and we need to sort of take a harm reduction approach towards really reforming our laws to enable women to have access to safe abortion and also post-abortion care whenever they need. The desire for privacy is very important as a motivator for seeking telehealth. Other studies have shown that women would choose social safety as opposed to technical safety. So they know that at the facility, they are guaranteed of technical safety. But if the facility also exposes them, then they will choose other routes that guarantee social safety rather than technical safety. So the desire for privacy and secrecy here is so important, because then we should be able to design programs, SRHR programs, that guarantee safety and privacy and that non-exposure beyond even abortion, even to family planning and other related services, to enhance uptake of these services and for women to really feel that their needs were taken care of in a respectful manner and in a way that guarantees their privacy. Abortion costs, definitely, as I've explained. So whereas the public sector does not offer safe abortion services, at the end of the day, when these women seek care in other private facilities face-to-face, sometimes it's very costly and they may not be able to afford. So that's how they get redirected. For those who cannot maneuver and navigate to finally raise the resources, they end up with unsafe abortion. So abortion costs still, the lack of abortion services or broad access to safe abortion services, again, is an injustice to women. And it's a policy recommendation, really, that we enhance our efforts around advocacy to reform the law, to remove these criminalizations and restrictions that exist. And then finally, the desire for empowerment is again super important, because when women are empowered, of course, you enhance their autonomy, you enhance their sense of agency, and the ultimate outcome are normally positive outcomes. So these findings are really strong in providing insights to policymakers in terms of how to design programs, but also what is needed to address the challenge of abortion and unsafe abortions in Kenya, and ultimately to improve the health and well-being of women. Thank you.
Kenneth, what you were saying brings us very nicely towards matters of self-care. And this podcast is being recorded during Self-Care Month, which aims to raise awareness of the importance of self-care and self-care interventions so as to benefit people's lives and health. Self-managed abortion is increasingly recognized as a core self-care intervention. Hazal, how do you see services like telehealth abortion and women on web fitting into a self-care framework?
Thank you for the question. So Women on Web is a digital community of healthcare practitioners, activists, and researchers providing online abortion care and information and help on abortion care. And individuals can come to Women on Web, a website, complete an online consultation and access information and help for what we call for abortion in dignity and with respect. And these are, we believe, values essential for quality abortion care. So Women on Web is one of the first international telemedicine abortion service to exist. And actually this year we are celebrating the 20 years of Women on Web. So it's been quite a while that we're around. And indeed, Women on Web had a role in terms of advocacy and research for telemedicine abortion, not only providing this critical care where or to whom it is not accessible or just simply offering it as an additional choice and for comfort during abortion process, but also showing how telemedicine and self-care in abortion provision is viable and can really be an alternative service delivery model. And of course, I mean, self-care is a framework that we embrace, but at the same time, online abortion is also about community care for us at Women on Web. It's also about health equity, and it's also about social justice. And just as Kenneth mentioned, unsafe abortions are public health failures and violations of human rights, and they can be remedied by policies and laws, but also perhaps with telehealth services like Women on Web. And what this study is really saying is that those local policies and laws should incorporate self-care measures such as telehealth.
Thank you, Hazal. Let's have a look now into the wider implications of the study. Turning to you, Céline, could you tell us a little about why it was important to publish this paper? What knowledge gaps does the paper fill?
Yes, thank you very much. Well, specifically about this knowledge gap, I think that up until now, Women on Web data has been analyzed in the context of several countries, but mostly in the US and in Europe, for example. There are research that has been conducted in Ireland, in France, and Germany, and we thought it was important as well to turn to other settings and to look at who used the services and how they were used, also in Kenya, for example. And I'm very grateful that we did that, filling a gap, specifically online abortion for people living in Kenya. And we can see that indeed it can be very much linked, this use of Women on Web in Kenya, to some gaps in the health system. So that's one of the gaps that we wanted to fill. And in terms of the broader picture, policy and practice, I think this kind of research is important to really connect the kind of online practices that exist, mostly outside official health systems, to what can be done actually in official health systems and through policy and the development of new practices. We have seen in recent years an increase in the use of teleabortion, and that comes, as Hazal said, from two places, either because of restrictions, either because of a positive need for alternative models of care and self-care, as you mentioned. But this increased use has led to the acknowledgement as well in some official institutions and organizations of the relevance and the legitimacy of such practices. For example, it is now part of the WHO guidelines on safe abortion. What could be important, what this kind of research could lead to, is the acknowledgement in more instances of teleabortion as a safe practice for abortion. For example, we have seen with the COVID pandemic that a lot of countries have also decided to integrate online models, dematerialized models, in their official route for abortion services. It has been the case, for example, in the UK. It has been the case in France, but some have resisted that trend. And for example, in Germany, this is still not totally part and parcel of the health system, and it's still an in-between that is difficult to manage. So I guess in the future for practice, it would be wonderful to see that change and having more countries establishing more officially this kind of alternative models for abortion services. And we have seen, Hazal mentioned equity. We have seen that there's really an impact of teleabortion for health equity and more equitable access in better conditions for a lot of people who before teleabortion could not afford to travel far away, could not afford to leave children for a day to have an abortion in a faraway hospital. So this is also very important for this equity dimension, that more health systems integrate teleabortion.
Thank you, Céline. Would you like to also perhaps tell us a little bit about your perspective on where we go to from here? Are you planning further research, or are you planning to improve evidence for policy in the future?
Yeah, it's been a pleasure first to work with the Women on Web team, who gracefully shared their anonymized data to help support research. So there are plans to write a bit more about this data, about other countries, and maybe to do some international comparisons as well. But also, I guess it's important to always bring back those data to policymakers in the different countries. I don't know if Kenneth wants to say a bit more how this could be implemented in Kenya, for example. But I know that in Germany, for example, there are some where I live, so I can talk a bit more about that. There are a lot of different positions that are not in the system, that are not always favorable to the diversification of services for abortion, with a very protective attitude of hospitals and gynecologists in hospitals, who are up until now the only ones who can officially perform abortions in Germany. So this kind of model has to be sold, right? You have to convince people a lot and have a lot of conversations in private and public meetings to be able to help advance this practice. So I think that's also the next step. So more research, of course, so that we have more evidence to build on, but also a lot of discussion to try to change in different circles and influence how services could be further developed.
Thank you. So, Kenneth, would you like to answer the question about whether there are plans for future implementation in Kenya?
Yes, certainly. So the Ministry of Health has recently in Kenya, over the last 3 years, developed a lot of interest around self-care. They commissioned a study just to pilot how self-care for family planning and contraceptives could be implemented. They have not yet gotten to the abortion space yet, even though I know it's happening already. So because of the interest, and this interest was expressed through them developing guidelines on self-care, which was a really good step. They've also, from the era of COVID, been keen on telemedicine as an alternative approach to enhancing access to services for women. And so, again, there's been efforts to develop telemedicine sort of guidelines. So we see this as an initial step, and I think this particular data could begin to show what initially has just been mentioned in anecdotes, that for sure women are able to access successfully teleabortion services, and that the outcomes are positive, and that the experiences are, if not better, but similar to even if they saw a provider face-to-face. Of course, in this case, they save money, they save a lot of face-to-face interaction. So it is definitely an insightful conversation to have. In the recent past, the ministry has sort of been a little keen to use data for purposes of policy formulation. So they don't we do abortion research. Previously, it would be a very difficult conversation with the ministry. But just this year, we've launched an incidence of abortion survey, and we partnered with the Ministry of Health, and they're the ones who launched the findings. So you can see how things have shifted over time. So I think this is definitely a topic that they can engage in and hopefully move things in terms of policy and practice and strengthening providers. There is, of course, during the self-care guideline process, there was some tension between providers and those who are then developing the guidelines, self-care guidelines. The tension was that providers who are feeling that their work is being taken away from them, will they ever have clients, especially the private sector providers? So some of these tensions and maybe misunderstandings could also be addressed at the policy level so that everything is streamlined. Thank you.
Thank you, everyone. That was a very useful deep dive into your perspectives of the paper, and it was very good of all of you to be here today. This study reminds us that telehealth abortion is not only a safe and effective healthcare intervention, it is also a means toward reproductive autonomy and empowerment of individuals, especially in legally and socially restrictive settings. In 2022, the World Health Organization updated its guidelines on abortion care, which recommends telehealth or telemedicine as a means to deliver abortion services, as a self-management option for medical abortions less than 12 weeks, and self-administration of injectable contraceptives in the post-abortion period. So, thank you to all our guests, Céline Miani, Kenneth Juma, and Hazal Atay, for sharing their insights on an evidence-based means which equips people to be more empowered over their health and well-being. You can read the full study at srhmjournal.org, Please also see our open call for papers to the Sexual and Reproductive Health Matters open issue and a call for a special collection on ensuring access to abortion as a matter of rights, equity, and justice. Please share, subscribe, and join us next time on the SRHM Podcast.
Thanks for joining us for this insightful conversation. Please check the show notes for a link to the SRHM Journal, which is available online and open access. Follow us on social media and sign up for our newsletter to receive notifications for new publications. If you're enjoying this podcast, please subscribe, give us a rating, or leave a review. Sharing evidence-based and rights-grounded knowledge is our passion, and it's also critical to support the advocacy and actions that need to be taken to improve SRHR for all. We would very much appreciate it. Thank you for supporting the SRHM Podcast, which is produced by our staff. The music was composed by Tiber Christian and Salomon Beautombe.